Hi, everybody. Welcome. It is a gorgeous Saturday, so I'm so excited you guys are taking this hour to spend with Parkinson's Support and Wellness. I am Julia Burks. I am the Assistant Director. I am covering Chris today while he's in DC with his grandkids. So we're all sending them positive vibes and wish he was here, but super excited that he's spending time with the family. Like I said, my name is Julia. This is our May PDEDU session, Medications for Parkinson's. We are super excited that you're all here today. I'm going to pass the baton to Maureen to get us going.
Hi, everybody. I have the pleasure of introducing my best friend, Dr. Jacob. She came to us in 2012 after her residency at IU in Indiana and did a 2-year fellowship with us and then stayed on. She's wonderful to the patients. She's a great friend. She's kind, she's generous. I could go on forever, but the most important thing is that we drink wine well together. So Dr. Jacob, thanks for doing this with us.
No problem. Thanks, Maureen. I'm going to start sharing my screen now. Can everybody see that screen? Julia, can you give me a nod if you guys see that? Awesome. Great. So thank you everybody again for taking time out of your day, out of this beautiful day. Of course, finally we have a nice Saturday and here you are. Yeah. I appreciate it for coming. So I'm going to talk today about medications for Parkinson's, the old and the new. So for those of you who have been around the block a while, some of this will be redundant to you, but I feel like I can't talk about new medicines without talking about the old medicine. So it's kind of going to be an an all-encompassing view of the medicines we currently have available for Parkinson's. I don't have time, unfortunately, to talk about things in the pipeline or things that are undergoing research. So all the medicines I'm talking about today are currently approved and used for Parkinson's, okay? All right, let me see if I can. There we go, okay. So before we talk about the individual medicines, I think it's important to talk about medication treatment goals, right? So what are we looking to help when we're starting a medicine for Parkinson's? And so I break it down into 3 different categories. The first is we're looking to improve motor symptoms, right? So these are physical symptoms that we see with Parkinson's. We also are looking to improve non-motor symptoms.
I can see what I mean. I can't get the sound.
Okay, where are you? And other features of Parkinson's that can be just as disabling as the motor symptoms. And then we also use medication to treat side effects of the medications. And so I'm going to hit on really all of those different categories regarding the medicines we use in Parkinson's. So when we're talking about treating motor symptoms, what are we looking to help? So we're looking to help things like tremor. So this is shaking. If you have shaking, some people with Parkinson's don't have shaking. If you have bradykinesia, so this is kind of a fancy word for slowness to movement. We're looking to help rigidity, which is muscle stiffness. We're looking to help your gait. So things like shuffling, freezing, that's where your feet get stuck on the floor and you can't pick up one foot in front of the other. Festination, this is when you take tiny steps and you go faster and faster and faster. And then we're also looking to help things like dyskinesia. So if you don't know what dyskinesia is, it's wiggly movements we can see with Parkinson's that sometimes it's a result of the Parkinson's plus the medicines we can give for Parkinson's. And really what our goal is to give you more on time. This is where your motor symptoms are controlled with minimal dyskinesias and less off time, where your physical symptoms are not doing well. And so the next several slides, I'm going to talk about medicines that primarily are looking at improving motor symptoms of Parkinson's. And so Carbidopa Levodopa, also known as Sinemet or Sinemet IR, is one of the mainstays, probably the mainstay medicine we use in Parkinson's. It is still the gold standard medicine.
I can't hear you.
And it's still you can't hear me? Can everybody else hear me?
I will reach out to that participant to try to figure out a solution. Okay. I will be in touch.
Great.
Can everyone else hear? Can everyone nod? Okay, great.
Good. And so it's been, Carbidopa Levodopa has been around since the 1960s. It really is still the most effective treatment we have. And basically it's two medicines. So levodopa is dopamine, right? So levodopa gets broken down in your body to dopamine. Your brain doesn't recognize it any differently than the dopamine that we make inside of us. That carbidopa in there is just meant to prevent the side effects of levodopa, okay? So it helps prevent the breakdown before the levodopa gets to your brain. So it helps with things like nausea that may come along with Sinemet. I usually start this medicine at a half tablet to 1 tablet 3 to 4 times a day. And then we adjust from there based on your symptoms. So it is really individual dependent how much we give you and how we dose it. And so you may be on Sinemet and somebody else may be on Sinemet and you could have a totally different dosing regimen than them. And so it's really kind of individual based what we do with that. Just a side note, carbidopa, levodopa, these little yellow pills can be crushed. Like, so if you can't take a full pill, you can crush it and eat it in applesauce. So that's something to be aware of. And you'll often hear us say, take it away from meals. And this is because protein in food can compete with its absorption in the gut. So we'll say, take it at least an hour before or after you eat meals, if you can. So now we're going to shift to other formulations of carbidopa levodopa, okay, that you may hear about. One is Sinemet CR. So this is controlled release carbidopa levodopa or controlled release Sinemet. This medicine has been around for a long time, but it really never panned out to be that long-acting medicine during the day that we wanted it to be. And that is because it is less reliable in its absorption during the day. So it's even more likely to have interference with food during the day than regular Sinemet. And so oftentimes patients say it doesn't kick in or it doesn't work well. The exception is nighttime. You'll see us add this a lot at nighttime because you're not eating overnight. And sometimes we can get a little more bang for our buck overnight with this medicine. And so we may use it at that time. Parcopa is, again, carbidopa levodopa, but it's an orally disintegrating tablet, okay? It does not get sublingually absorbed though. All it does is kind of start to melt in the mouth. You still have to swallow it and it still gets digested in your gut. The idea with this medicine was that you could take this medicine without needing water. I'll be honest, I don't prescribe it a whole lot. I have some patients that are on it. I find it a little more difficult to get and not a lot of pharmacies have it and it can be a lot more expensive. And really, again, you're still having to swallow the pill. And so again, the one benefit is, oh, maybe you don't have to drink water with it. And then carbidopa, levodopa, and entacapone, or Stalevo, is a combination pill where you're combining Sinemet with a drug called entacapone that I'll talk about a little bit later. But entacapone is essentially a Sinemet extender. So it helps your Sinemet last longer. So this company just put all 3 of those medicines in one. And so it's nice from a pill burden standpoint because you're only taking 1 pill. The downside, again, is it may be more expensive and it's hard to up titrate. So if we wanted you to take, 1.5, we wanted to increase your carbidopa levodopa, we couldn't just say, oh, take 1.5 of Stalevo because you can't take more of the entacapone. And so that's a little bit of the downside of that medicine, but some people like it if they're really stable on a dose of carbidopa, levodopa, and entacapone, we may use that. Raitari is one of the newer medications in the last several years to come out, and it is essentially carbidopa, levodopa, but it is an extended release formulation that they're capsules and they contain beads of carbidopa and levodopa that dissolve at different rates. So it's supposed to have immediate effects and delayed effects. So the idea is it lasts longer and gives you better coverage than Sinemet. And so in patients, when I start to think about using this medicine is when somebody is taking regular Sinemet, they're taking it at least 5 times a day or more, and they're still having wearing off. Or maybe they're taking Sinemet 5 times a day and we've tried adding other medicines to make the Sinemet last longer and they're still having wearing off. Then I start thinking about Raitari. Raitari replaces your regular Sinemet. So you don't usually use it in addition to, although there's some exceptions there. But for this purpose, we usually convert them from patients from Sinemet to Raitari. And you can open these capsules too and sprinkle the beads on food if you need to. And then this does, again, require a prior authorization from your insurance company. And it may cost I would say it usually does cost more out of pocket than your Cinemet. Some people really like the Raitari. Some people, we switch them to Raitari and they say, you know what, either the benefit isn't worth the cost, I want to go back to regular Cinemet, or they just don't have the same effect from Cinemet. So it's really a trial and error process. So we say, okay, give it a little bit, we'll adjust the dosage, see if you like it. And some people do, and then some people don't. It just really depends on the individual. And then lastly, in kind of the dopamine category, the Carbidopa Levodopa category is inhaled levodopa. This is the newest levodopa medicine to come on board. This is called Ambrisia, and it's used as a rescue inhaler for off periods that occur between your levodopa doses, between your Cinemet doses. And the idea is it's a fast-acting medicine, so it can work within 10 minutes of taking it, and it usually lasts up to an hour or longer. And it can be taken up to 5 times daily as needed, but it's really used as a rescue medicine. So instances I think about using this is if somebody, say, they're fairly stable on their medication regimen, but maybe they have wearing off some days, but other days they don't have wearing off, or maybe they have wearing off that is unpredictable or happens, in the morning one day and the next day it's in the evening. So they don't have wearing off where we need to shift all of their medicine, but this will serve as kind of a rescue for those time periods. So it gives them a little bit of flexibility. And again, you take it to bridge you to your next dose of levodopa. Side effects of this that are above and beyond what we would normally see with Carbidopa Levodopa is cough, right? This is, if you see the picture here, it looks like a little kazoo, we always say, and you take it apart and you put these 2 capsules in it, and then you crush the capsules and it makes a powder, and you inhale that powder, and some patients report coughing when they're inhaling that powder. We avoid use of this in chronic lung diseases like COPD and asthma. So if you have those things, this probably is not the best medication for you. So shifting gears a little bit. So I was just talking about dopamine medicines that are the actual dopamine neurotransmitter that we give. The next class of medicines I'm going to talk about are called dopamine agonists. So these are medicines that stimulate the dopamine receptors in the brain. You may have heard of these. Pramipexole and ropinirole have been around the longest. There are extended release formulations of those medications as well that are dosed 1 time daily versus 3 to 4 times daily for regular pramipexole and ropinirole. There's also a patch form of this called rotigotine. The extended release formulations in the patch, again, from a price standpoint, can cost a little bit more. So it really just depends on what your preference is. And a lot of times if patients are already taking other medicine 3 times a day, they're going, well, I don't have a problem taking pramipexole 3 times a day if I'm already taking all these other medicines 3 times a day. But for some patients, it can be helpful to do that 1 time daily dosing or using a patch. These medicines tend to be less potent than the Carbidopa Levodopa. So I will use these medicines in some patients early on in Parkinson's that maybe have mild symptoms and maybe they're younger. So as we get older, this class of medicines can cause a little more side effects like hallucinations and things like that. So again, younger patients with maybe mild symptoms, I may go for a dopamine agonist first. Sometimes I'll use this in combination with Cinemet, and so patients are on both. These medicines are also used to treat restless leg syndrome. So if that is something that you're dealing with in Parkinson's, we may add that one of these medicines maybe just at bedtime. So that's the kind of pill and patch form of dopamine agonists. There's also an injectable form of a dopamine agonist. It's called epimorphine or Epikin. This, similar to that Ambrisia inhaler I talked about, is more of kind of a rescue medicine. This is not a mainstay medicine that you would take all day long, but it's meant to bridge those periods if you have a sudden off and you're not due for your next medicine, or maybe your offs are so bad that you have a hard time swallowing pills during those times. This is an injection that you or your caregiver can give you, and it creates a rapid on, but it has a short duration of action, so it doesn't last long. So again, it's just serving as a bridge to take the medicine. Somebody's coloring on my screen. This you have to titrate in the office. So you have to come into the office. One of our nurse navigators will actually help give you a trial of this, and that is because of side effects. So some patients will have significant lightheadedness or maybe fainting when they get it. Some can have severe nausea and vomiting with it that requires taking another medicine with it. So, so this, again, it can be a little bit more cumbersome to start this medicine in patients. Now, there is one of the newest medicines to come out is a sublingual form of this medicine. It's called sublingual apomorphine. The brand name for it is Kimobi, and this is actually a sublingual. Sublingual just means under your tongue. So this film gets placed under your tongue, and again, it's a rescue medicine for your off periods. Short acting, so it's just going to bridge that period where you feel off so you can get to your next dose of medicine. This again can be taken up to 5 times a day, but it has to be at least 2 hours apart. And there is a trial period to figure out your correct dose. So the company will send you kind of films of all different dosage, this kind of starter pack. We kind of figure out which one works best for you. This can have those similar side effects to significant nausea, vomiting, lightheadedness. So that's something we have to be aware of too. And sometimes we have to add medicines for that. But this is probably more attractive, I would think, than patients giving themselves injections, which I think some people are a little skittish about, totally understandable. So that it's nice that we have this option now. Moving on to a different class of medicine. So again, the last medicines I talked about stimulate dopamine receptors, and then the other class of levodopa was the dopamine neurotransmitter itself. These are medicines that prevent breakdown of dopamine, whether it's the dopamine you're taking in pills or the dopamine that your brain is making. So COMT inhibitors are medicines that prevent the breakdown of dopamine you take in pill form. COMT is just an enzyme in your body, and its job is to chew up dopamine. And so these medicines that you see listed here, entacapone, tolcapone, and the newest one, opicapone, are in addition to your Sinemet, so or Carbidopa Levodopa, if that's what you're taking. And the whole idea is that they're going to help your medicine last longer. So if you're taking Sinemet, say 4 times a day, and you're taking it at 8, 12, 4, and 8, and it's wearing off an hour before your next dose is due, your doctor may say, hey, let's add entacapone, and you have to take it with your Sinemet. Or tolcapone is actually an older form of this medicine that I'm finding it harder and harder to get, but it tends to be more, it's really effective. We do have to monitor liver enzymes with that medicine though, because there have been rare cases in the past reported of hepatic toxicity. And then opicapone, you just take once daily. And again, this is this newer medicine. It is not generic, obviously, since it's new, and so it may cost a little bit more, but works in the same way those other medications work. Now, MAOB inhibitors, again, MAOB is just an enzyme in your body, and it likes to chew up dopamine. And so these medicines inhibit that enzyme. And so you'll see there selegiline, rasagiline, which have been around for a while, and then sulfonamide or Xadago is the newest form of this. They all work very similarly to inhibit that enzyme, again, that chews up dopamine. Selegiline and rasagiline, you don't have to be on Sinemet to take these. These actually you can take on their own. So maybe if somebody has extremely mild symptoms, they just want a medicine that's once or twice a day, which would be one of these medicines, they may opt to try that. Again, it's not as potent as the dopamine agonist or the medications like Sinemet that are going to give you kind of more symptomatic control of your motor symptoms, but they're an option that's out there to be used first line or in addition to the other meds you're taking. And then sulfonamide or Xadago, it was studied in patients that were on Sinemet. So when you prescribe it, it says patients taking Sinemet can take it. So usually that's used in patients already on Sinemet. Amantadine is a totally different class of medicines. It's actually an old antiviral medication. And we primarily use amantadine for the treatment of dyskinesias and Parkinson's disease. So dyskinesias, again, are kind of these excess movements we may see in Parkinson's. And so amantadine would be the drug that we kind of reach to if you're having problems with that. It can be helpful in treating some other Parkinson's symptoms like tremor, but by far and away, we use it mostly for dyskinesias. It can be dosed anywhere from 1 to 3 times a day. It really depends on how often you're having dyskinesias or when you're having dyskinesias. So for example, if somebody tells me they're just having dyskinesias in the evening, I may just give them amantadine in the evening. Whereas if somebody's having dyskinesias maybe throughout their day, I would dose it 3 times a day throughout their waking day. Gocovri is a new medicine. I don't know if you've noticed, but I put asterisks near all the new medicines that have come out in the last couple of years. But this is a long-acting form of amantadine. So the benefit of this is that you take it 1 time a day versus 3 times a day of amantadine. And again, it's used for dyskinesias and Parkinson's. There's some, when they studied this drug, they felt there was some signal that it may help off time in some patients. Again, because it's a newer drug, a lot of times insurance companies make us do a prior authorization for this. They may deny it. We may have to kind of go back and forth a little bit with it. And it can cost more, just again, because it's not generic. And so it can cost more than regular amantadine. So, so that can be a factor in deciding which one we put you on, amantadine or Gocovri. And so a lot of times, patients want to know, well, what should they be looking for when we start them on a new medication? And that's a really great question, and one that sometimes we forget to talk to our patients about. But really, when I start a new medicine for the motor symptoms of Parkinson's, I want to know, are you getting benefit from it, right? And is that benefit a complete benefit or incomplete benefit? So I want to know, well, is your tremor better? Is it easier to move? Are you shuffling less? Are you having less rigidity? And so if your medicine is working and it's on, you should be feeling an improvement in those symptoms. And then I want to know, okay, if you're having benefit from your medicine, is it lasting dose to dose, or you're having wearing off before your next dose is due? Because that helps us know how frequently we need to give you medications, or if we need to add on other medicines to help it last longer. And then I also want to know about dose failures. Okay, so this is where for the most part your medicine works, but you'll sometimes have doses that just don't kick in at all. And again, if this is occurring, we always ask, are you taking your medicine away from mealtime? Specifically, again, if you're on Carbidopa Levodopa, because of this issue with protein interference. So if you eat a big meal with your Sinemet, it may not kick in as well because protein is competing with the Sinemet for absorption in the gut. And then I want to know, are you having side effects, right? It really doesn't help you if I'm giving you a medicine that helps your maybe your motor symptoms, but you feel so sick all day long from nausea that, you're not eating. So we always want to know about those things so we can tackle those things. And so what can those side effects be? And so again, I've mentioned this already, but nausea and vomiting is one of the most common side effects we'll see with some of our Parkinson's medication. Again, primarily Carbidopa Levodopa, but we can see it with other medications as well. This will usually improve with time. So the longer you're on those medicines, usually the better this gets. If you're having issues initially taking your medicine because of nausea, I'll say take it with some crackers or maybe some ginger snaps or something that can kind of help settle the stomach, something that's a carbohydrate. Again, you want to avoid a lot of protein with your Sinemet, but so crackers or something would be a good option, and see if that helps settle your stomach. But if the nausea continues and it's just intolerable, or maybe you're vomiting and having nausea, we may use extra Carbidopa. Again, so that's that medicine that Sinemet is Carbidopa Levodopa, and that Carbidopa helps prevent those side effects that occur. So we may add more Carbidopa. If that doesn't help, or maybe that's too expensive of an option because Carbidopa can be pretty pricey, we will sometimes get a medication called domperidone from Canada, which tends to work very well for our patients with Parkinson's. Unfortunately, it is not available in the United States, but we have a way that we order this for patients if needed. And then again, over time, it can improve. And a lot of times, even if you are taking one of these anti-nausea medicines, you're able to come off those eventually because the nausea goes away. Another side effect, a dose-limiting side effect that I ask about is lightheadedness or fainting. In Parkinson's, blood pressure can fluctuate, okay? So over time, we may see more fluctuations in patients' blood pressure, and that can lead to lightheadedness or fainting. We call this orthostatic hypotension. This is a problem that is intrinsic to Parkinson's, but when we add medicines for Parkinson's, it can sometimes exacerbate this problem. So that's one side effect to look out for as well. Another dose-limiting side effect we may come across is dyskinesia, which I already talked about. If it's tolerable, so say you have mild dyskinesias, but you're otherwise stable and your motor symptoms are well controlled, we probably aren't going to make any changes to your medication because some mild dyskinesias, usually we kind of accept that. However, if dyskinesias are really bothersome, or maybe they're affecting your balance, then we may consider adjusting your medicine. So maybe shifting your medicine down, but giving it more frequently, or we may add one of those medicines like Amantadine or Cocomt. We can see, so with Parkinson's itself, patients can have hallucinations, delusions, paranoia, and compulsive behaviors. So compulsive behaviors are where people want to do things compulsively. Classically, we think of patients gambling compulsively, or maybe they're shopping compulsively, or maybe they're having hypersexuality. So all of these things can be a problem with Parkinson's, but sometimes the medicines we give for Parkinson's can make those worse. And so we always want to know, if we increase your medicine or we add a medicine, are you having side effects? Because we may need to decrease or stop those medicines. And certain medicines like the dopamine agonists and Amantadine can be more culprits at causing these problems. So again, a dose limiting side effect that we want to watch out for. We're going to shift gears a little bit. I know that was a lot of information about kind of controlling motor symptoms, but I want to talk about motor symptoms of Parkinson's and how we treat those with medication and non-medication options to treat them too, because these symptoms can be just as disabling as the motor symptoms and sometimes more disabling. So mood disorders are a non-motor symptom of Parkinson's, and those include things like depression, anxiety, irritability, apathy. Apathy is just lack of motivation, which is really common in Parkinson's. If these symptoms are mild and maybe they're happening infrequently or maybe a couple of times a week, but they're not greatly interfering with kind of your day-to-day life, we may recommend, hey, let's, try to increase your exercise, which can always help depression and anxiety. Maybe get involved in some new hobbies or try to get some more social engagement and activities, because those things can help with these problems. However, if these problems are persistent despite doing those things, and they're really interfering with your day-to-day activities, we may recommend medication. And so here's a long list of those types of medications we will use in Parkinson's. These are known as the selective serotonin reuptake inhibitors, or SSRIs, or serotonin norepinephrine reuptake inhibitors. You don't have to remember that, but you hear us talk about those. These are the medicines we're talking about. And I have used all of those medicines in patients with Parkinson's. And a lot of times, what will work for one person, so one medicine will work for one person, but it won't work for another. So it may be a little trial and error to figure out which one of these medicines works for you. I always tell patients, at least give it 4 to 6 weeks on one of these medications to see if it's working, because they take a little bit longer to build up in your system. Older class of antidepressants are called TCAs, so that it includes amitriptyline or nortriptyline, which can be used in Parkinson's. We have to be a little bit more careful with these. They can cause more side effects like sleepiness and some blood pressure issues. And so those ones I don't use as much, but they are available. And then benzodiazepines are a different class of medicine. Sometimes we will use this if patients have severe anxiety and maybe they're on an SSRI, so one of the medicines in this top column, this here, but they're still having periods of panic attacks. And we may add an as needed dose of clonazepam or Ativan if those symptoms are severe. But those we have to watch for side effects, because that can make you sleepy and have some cognitive issues. So we use those sparingly, I would say. I already touched on this a little bit, but again, hallucinations, illusions, these can be non-motor symptoms of Parkinson's. And hallucination is basically seeing or hearing things while you were awake that are not there. So a lot of times people say, oh yeah, I have these dreams that are just wild, and it's not dreams, it's when you're awake, you're seeing things that aren't there. And usually in Parkinson's, it's either animals or small people or children. Sometimes it's as simple as, you see a spot on the carpet that looks like a bug that's moving, or somebody will say, a lot of people say they see shadows out of the corner of their eyes. So these are hallucinations. Illusions are where something looks like something else. So maybe you'll see a mailbox and you think it's a person, and then you're like, wait a second, no, that's a mailbox. That's an illusion. So initially, patients with Parkinson's will retain insight. They'll know that it's not real. But sometimes later on, patients can lose that insight and they really think something, an animal is in their house or other people are in their house, and that can be really frustrating for the patient and for their caregiver. Similarly, patients can have delusions in Parkinson's. So these are false beliefs, not based on fact. So it may be a pervasive thought that their spouse is cheating on them, or maybe that there's another person living in the house or something called Capgras phenomenon, where they think their spouse is an imposter spouse. These, as you can imagine, can be really, really frustrating and difficult for patients and their caregivers. And so a general rule is for treatment of these, that if the hallucinations are mild, so say they're having, they're seeing somebody's seeing a shadow out of the corner of their eye, I will usually never treat that. But if they are significant and they're bothersome to the patient, or they're affecting, the day-to-day life of the patient or their caregiver, usually we'll look at the medicine list that they're on, the Parkinson's medicine, and we may adjust, we may decrease medicine, we may stop certain classes of medicines like Amantadine if they're having these problems. And then if those adjustments don't help, or say we're not able to adjust the Parkinson's medicine, then we may add a medicine. So here's a list of medicines that we'll use for these problems. Ribostigmine or Exelon is a medicine we'll use particularly in patients that have cognitive impairment and hallucinations. Other medicines we will often use are quetiapine, clozapine, and a newer one called pimavanserin. I have some patients where we've used all of these. And again, sometimes it's a trial and error process to figure out which is going to work best for the patient. Clozapine is a really good medicine for these symptoms. Unfortunately, it requires a frequent blood draw. You have to have a blood draw every week for at least 6 months. And then from there, you have to continue doing blood monitoring. But again, we may have to go to that if these other medicines don't help with the hallucinations or delusions. Cognitive dysfunction, another really common non-motor symptom in Parkinson's. So patients often will complain about difficulties with concentration, with multitasking, planning. Maybe they just have slowness to their thoughts. So they say, gosh, it just takes me forever to respond to somebody, and they think I don't know, I don't hear them, but it's just taking me a long time. Maybe they're having problems with word finding difficulties or with their memory. And so we classify cognitive problems in a couple of different ways in Parkinson's. Mild cognitive impairment is where you're having small changes in the thinking and memory, but they have little impact on your day-to-day activities. And so this is really common in Parkinson's. Actually, when we look at all patients with Parkinson's, at the time of diagnosis of Parkinson's, often about a third of patients will have some form of mild cognitive impairment. Now, conversely, dementia is where you're having cognitive problems, significant changes to cognition, thinking, and memory that are impairing your day-to-day activities. The prevalence of cognitive changes does increase with age and with the duration of the disease. And it's best, cognitive problems are best assessed by formal neuropsychological testing because this is kind of, it will show us overall what degree of cognitive impairment you have. And it will kind of give us patterns of where you're having difficulty. And sometimes we're surprised. Sometimes if somebody has a lot of, maybe memory complaints or concentration complaints, we may get neuropsychological testing and it may show that, hey, there's not a primary memory deficit here, but there's more anxiety and depression that are probably causing some of those anxiety or some of the attention and concentration difficulties. And we may treat that by using a medicine for anxiety or depression rather than treating you with one of the cognitive medications. What can be done to help your cognition overall? So exercise, we all sound like broken records when we talk about exercise, but exercise not only helps your physical symptoms of Parkinson's, but absolutely has been shown to help cognition. And so regular exercise is so important. You want to stay socially engaged. You don't want to sit around watching TV all day. That's not good for your brain. You want to make sure you're getting adequate sleep, good nutrition and hydration, and limit alcohol. I don't ban alcohol at all in Parkinson's, but if you're drinking like a moderate amount most days of the week, it can impact your cognition. So you may want to limit yourself to 1 glass, of wine a night or something like that. You want to limit medications that can worsen cognition. So this is something that your doctor can help with. So, going through your list of medicines and say, okay, well, this medicine may be a culprit in causing some of the cognitive problems you're having. And then you want to treat other medical conditions, obviously, that could contribute to your cognitive issues. Sleep apnea is a big one. So patients that have, a lot of snoring or they stop breathing at night, these patients, we know if they have untreated sleep apnea, it can affect their cognition. And so we always want to be aware of those problems because, again, wearing a CPAP then at night, which is the treatment for that, can help cognition. Similarly, things like low thyroid, B12 deficiency can all contribute to cognitive issues. So something to talk to your doctor about, or even your primary care doctor should be kind of checking those things if you're having cognitive problems. And then this problem of orthostatic hypotension, so the blood pressure fluctuating, can cause cognitive difficulties. Always important to keep a pill box and set alarms to remember when to take your medicines. You guys are amazing in that you have to take all these pills through the day, and it's so hard sometimes to keep track of. And so, especially if you're having some cognitive difficulties, you want to make a plan. You want to keep a pill box and set alarms. Because what you don't want to happen is you don't want to miss medicines, or you don't want to double up on medicines that then can more impact your cognition further. And then again, aside from all of those other kind of measures, medication treatment for cognitive dysfunction in Parkinson's includes medicines like ribostigmine, which I talked about a little bit before with hallucinations, donepezil, galantamine, and memantine. These are all medicines that are used for significant cognitive dysfunction in Parkinson's. They're actually approved for dementia, not so much for mild cognitive impairment, but you'll see us use these in different settings for the cognitive changes in Parkinson's. Galantamine I don't use a whole lot, but ribostigmine and donepezil and memantine I'll use. Usually ribostigmine and donepezil I use the most. Moving on to sleep dysfunction. So sleep dysfunction is super common in Parkinson's. I would say insomnia is a bigger issue than hypersomnolence. This is where patients want to sleep all day and all night. But insomnia is where patients, you can't fall asleep, or you fall asleep, but you're waking up frequently during the night, and you can't get back to bed. And so treatment, again, conservative measures. So sleep hygiene, I am a big proponent of sleep hygiene. So you want to limit your screen time before you go to bed. So this isn't just true for teenagers, for adults too. You want to put away the phone, put away the tablet, put away the computer at least a couple of hours before bedtime. And this is because that light, that blue light from those devices, tell your brain that it's daylight. It kind of simulates daylight in your brain. And so even if you're sleepy enough that you fall asleep, your sleep-wake cycles can get a little bit messed up because, again, your brain is so reliant on light signals to help know when it's night and when it's daytime. So that can kind of scramble those signals, if you will. You want to go to bed at the same time every night. You want to try to wake up at the same time every day. I know that's easier said than done, but you want to try to make a habit of this if you can. Eliminate caffeine, obviously, before it says before bed there, but really if you're having problems sleeping, I usually say no caffeine after 11 a.m. noon hour because it may affect your nighttime sleep. Sometimes patients say, I fall asleep at night, but I routinely wake up at the same time every night and I just can't go back to bed. And sometimes it's because your Parkinson's medicines are wearing off, and it may be just enough that it wakes you up. And it's maybe not so obvious. It's not like all your Parkinson's symptoms seem worse, but it may be, again, just enough that it wakes you up and you can't get back to bed. And so if that's happening, we will sometimes adjust your Parkinson's medicine so that you can take them closer to bedtime, or maybe we'll add a medicine like Cinemet CR that you take before bedtime to help see if it helps with that period. Sometimes patients, when they wake up, if again, they're waking up at the same time every night, I'll say, try taking an extra one of your Cinemet overnight and see if that helps you get back to bed. And if it does, then there's our culprit. It's your medicine's wearing off overnight. If it's not an off symptom that's waking you up and it's just that you're having those difficulties with fragmented sleep, we can use medication. So melatonin is a medicine we'll commonly use with Parkinson's. You can get it over the counter. You're going to take it 1 to 2 hours before bedtime. And this medicine just kind of helps reset your sleep-wake cycles. There's other medicines like trazodone, mirtazapine, sometimes quetiapine that we can sometimes prescribe to help with sleep too. Trazodone, mirtazapine, and quetiapine are also mood medicines. So it kind of has an added effect. If you're having mood problems plus insomnia, we may try one of these medications. And then hypersomnolence is where you have excessive sleepiness. So you're sleeping all night long, but still you're super sleepy during the day. Again, first thing we're going to do is say, okay, are you taking any sedating medicines? If you're on pain medicines, like narcotic pain medicines or things like that, it may make you sleepy through the day. Rule out other medical conditions like sleep apnea again. And I know it sounds counterintuitive, but sometimes in my patients that are complaining of a lot of somnolence, or they say, gosh, I sit down and I just fall asleep, I'll recommend increasing their activity and their exercise. It is not uncommon for patients in Parkinson's to say, if I'm sitting idle, I fall asleep. But if I'm up doing an activity all day, I don't feel tired. And so a lot of patients will say, well, if you start to feel sleepy when you're sitting down, get up and go do something or take a walk outside or something. And oftentimes that can revigorate you and give you energy. Sometimes if you have a certain time of day where you're feeling really excessively sleepy, I will recommend you drink some caffeine. So a cup of coffee or something, as long as it's not interfering with your nighttime sleep, right? But this can be an easy way to kind of get your body going and get some more wakefulness. And then if those measures fail, we do have medications to treat hypersomnolence or excessive sleepiness and fatigue in Parkinson's. And you'll see them listed there. So methylphenidate, modafinil or armodafinil have all been used. And again, these are stimulant medicines, and they can help with that excessive fatigue or sleepiness during the day. REM behavior disorder is another sleep disorder that we'll see in Parkinson's, and it's where patients act out their dreams. So if this is mild, so some patients just either like laugh in their sleep or they're talking in their sleep, or maybe they have just some mild movements in their sleep. Usually I don't do anything about that. However, if they're having dreams that they're acting out and they're hurting their bed partner, or maybe they're injuring themselves. So some people will like whack the lamp on the nightstand, or they're waking themselves up frequently because they're punching or yelling or kicking. Then we may add medicines like melatonin again. Again, this is taken 1 to 2 hours before bed, or a low dose of clonazepam at bedtime we will use to treat this as well. And those can be really effective and helpful. Autonomic features in Parkinson's, so these are another class of non-motor symptoms in Parkinson's, are very common and can be super disabling. So orthostatic hypotension, I've touched on this now a couple of times during this talk, but again, this is where your blood pressure is dropping when you're sitting or standing, and it doesn't have to be right when you stand up. It can be you've been standing for a while and the blood pressure drops. And patients usually don't say, hey, come in and say, hey, my blood pressure is dropping. They usually say, I feel lightheaded, or I get periods where I feel like I'm going to faint. Or maybe it's not even that obvious. Maybe they just feel like they have no energy, or like they just feel like a wet rag. Some patients will even complain of cognitive dysfunction, or their family members or loved ones will say, sometimes, they'll have periods where it's just like they're a deer in the headlights. And oftentimes that can be because the blood pressure is dropping. And so how do we treat that? Well, the first thing we do is look at their med list, because if you're taking blood pressure lowering medicines, which so many patients are, because maybe they had a history of high blood pressure, we will often decrease or stop those blood pressure lowering medicines, usually with the help of your primary doctor or maybe your cardiologist, whoever's prescribing those medicines. And so sometimes that does the trick, and then you're not having those problems anymore. But say you're not on those blood pressure lowering medicines and you're having these symptoms, then we'll recommend measures like increasing your fluid intake. So water. I always say I don't count caffeinated beverages and I don't count alcohol, because those just make you pee. So increase your water intake specifically. Some patients will say increase your salt intake, and sometimes we'll even prescribe salt tablets for this. Compression stockings or TED hose can be helpful. So this is where you wear, and they have to be thigh high. The knee high ones don't work. They have to be tight enough that they're hard to get on, which sometimes is a barrier to using them, but they just compress the blood vessels in the leg, and that's what helps get the blood up to where you need to go. And then sometimes we'll recommend elevating the head of your bed by 30 degrees. This sounds kind of goofy, but at night, patients with Parkinson's that have blood pressure fluctuations like orthostatic hypotension, when they're laying flat at night, their blood pressure often shoots high. And so if you can imagine, if your blood pressure is shooting high all night long, you're sending off all kinds of signals in your body to get the blood pressure down, get the blood pressure down, get the blood pressure down. Well, then you go about your day and you're still having those things kind of going on in your body, and your body's confused. And now your blood pressure is low because you sent off all those signals overnight. And so by elevating the head of the bed 30 degrees, it keeps the blood pressure from shooting too high at night. so that during the day, your blood pressure can be more well-regulated. Exercise too can help with orthostatic hypotension. And so general exercise helps, but I'll often tell patients if this is really a problem that before getting up, especially if they've been sitting or laying down for a while, march their legs in place or like squeeze their glute muscles together, because this manually, so your muscles then manually are pushing the blood vessels in your legs to get the blood pressure up where it needs to go. Again, if all of those measures fail and you're still having these fluctuations and symptoms from those blood pressure fluctuations, we will add medicines to actually raise the blood pressure. And so those medications include midodrine, fludrocortisone or Florinef, and then droxidopa or Northera, which is the newest medication to that class of medicines. They all work a little bit differently. So one may work in somebody and not work in another person. I've had patients that have to take all three of these before. So it's really kind of figuring out what works for you. All right. And then moving on to another autonomic non-motor feature in Parkinson's, constipation. We know this is so common in Parkinson's. Diet adjustments like eating more fiber, prunes, increasing, again, fluid intake, specifically water intake, can be helpful for constipation. Oftentimes that is just not enough to control the constipation, and we will recommend medicine. So because we don't want you to get a bowel blockage, right? So if you're not having bowel movements, you're at risk of, plugging off your bowel, and that can be a problem. And so Miralax or polyethylene glycol is a powder that I often recommend patients take, and you mix it in a beverage. I always say to mix it in a hot beverage. I think it dissolves better, and then you don't taste it as much. It's safe to take every day in Parkinson's. If you feel like this makes your stools too loose, I'll say take a half capful every day, or maybe take a half capful every other day to kind of stay on top of the constipation. Metamucil is another over-the-counter medicine that we'll recommend for constipation. There's stool softeners like Ducusate. Sometimes patients will get on prescription medicine like Linzess, which can help some patients with constipation. In Parkinson's, there's this famous fruit paste recipe that we have in the clinic that sometimes we'll hand out, and it has like a recipe of how to mix like senna tea with prunes and all these different things to make a fruit paste that can help. Sometimes magnesium supplement can help with constipation. Again, you get this over the counter. Jokingly, I have in here sugar-free gummy bears for if you really need a laxative effect. So if you want to chuckle, go on Amazon and look up sugar-free gummy bears and read the reviews, because these are apparently the best laxatives out there. So if you're really in trouble, get some sugar-free gummy bears and take a couple of them. Don't eat the whole bag, because apparently then it's like Armageddon if you do that. And then sexual dysfunction is another non-motor autonomic feature of Parkinson's. For erectile dysfunction, we will sometimes prescribe medications for erectile dysfunction. Urinary dysfunction is so common in Parkinson's. More commonly is difficulty holding the urine. So patients say, oh, I get the urge to go and I have to go right away. And I may lose control of my bladder, or they may have nocturia. This is just when they have to urinate frequently overnight. Medications that can be used for that are things like oxybutynin, tolterodine, Vesicare, Myrbetriq. You got to be a little bit careful with some of these medicines. Sometimes medicines like oxybutynin and Detrol, tolterodine can have side effects of making more your blood pressure drop. So again, if somebody's having lightheadedness already, this may not be the best medicine for them. One of those might not be the best medicine for them. And also cognitive side effects sometimes with some of these medicines. So talk to your doctor about this, or your urologist. And I put on the bottom there, I almost always, if somebody is having significant urinary issues, I almost always refer them to urology, just to make sure nothing else is going on, no other contributing factors that maybe would be amenable to some different kind of procedure or something. So again, don't want to get the habit of just blaming it all on Parkinson's, and then patients could be treated a different way. Rhinorrhea is just a fancy word for a runny nose. We can see this in some patients with Parkinson's. It's not terribly common, and I'm not talking about like congestion, like if you have a cold or allergies and you're blowing your nose. Patients with this problem, it's like a faucet, they say. It's just drip, 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 and it won't stop. And so the treatment for this that's available is ipratropium nasal spray. Okay, so it's a prescription nasal spray. And so in those patients, I will prescribe this and it can be helpful. Drooling or sialorrhea it can be really common in Parkinson's and very frustrating for patients. And patients with Parkinson's actually don't produce excess saliva. The problem is they don't swallow saliva as much. So it often pools in the mouth, and rather than going in the back of the throat and swallowing it, it comes out the front of their mouth. We have a lot of different treatment options for this. One is called glycopyrrolate or Robenol. These are pills that you take that can help dry up those secretions. Atropine drops under the tongue are another treatment that we can use. We will frequently do botulinum toxin injections. So these are Botox injections in salivary glands. We do it right in the office. And this can help dry up those secretions. So your parotid glands are on the side here. And you have some submandibular glands, and these are what produces your saliva. So we inject those areas, and that can help. And then just a simple thing that sometimes people feel is helpful is to suck on a hard candy or a lozenge or to chew gum. And this just helps initiate the swallowing reflex of your saliva so that you're swallowing your saliva rather than it cooling and falling out. And then lastly, pain in Parkinson's. So pain can be a quite common symptom in Parkinson's, and the location varies from patient to patient. Sometimes it's low back, sometimes it's legs, sometimes it's shoulders. And it can have different qualities to it. It could be more musculoskeletal pain, like aching pains in the muscles. Some people would maybe have more burning pain. Dystonia, so this is where muscles take on certain postures, can be painful. So like somebody will have a foot that turns in or their toes want to curl under. So that's dystonia, and it can be painful. Sometimes it's really hard to determine if pain is related to Parkinson's or something else going on. So one question I often ask patients that are having pain complaints is, okay, does that pain get better with your Parkinson's medicine? And then does it come back when your Parkinson's medicine wears off? Because that's a good indicator that it probably is the Parkinson's, it is related to Parkinson's. And then we can adjust Parkinson's medicines to account for that. But if that's not the case, so say somebody has like excruciating back pain that's shooting down their leg, they have numbness in their leg, that needs to be evaluated in a different manner to make sure nothing else is going on, like a herniated disc or something that needs treatment from a totally different standpoint. So with that, I'm going to stop. I know that was a lot of information, but I'm happy to answer any questions that anybody has. They can either maybe unmute themselves, or if they want to write it in the chat, and Julia can then go from there.
I've got it.
Yeah, what's your question?
My question is, Bill is experiencing, and it just started a couple weeks ago, it feels like cool water is running down the back of his legs. Have you ever run into that?
Not commonly. Is it like in certain positions, or just like randomly it'll feel like cool water is going down the back of his legs?
It just runs down, it feels like it's running down the thigh and down on through the calf. But I know there's nothing going on, but I feel back there and it's dry, but it's just something new that popped up that it's got to have something to do with something.
Is it down both legs or just one leg?
Just my right leg, which
Just
is
your right leg? Yeah, I would keep an eye on it. And if you start to develop any like numbness or tingling like that, I would let your doctor know, because it may be a nerve type pain or something, like weird kind of neuropathic phenomenon going down your leg. If you're feeling it.
Very good. Thank you.
You're welcome.
I have a follow-up question. Is this material that you just shared with us, can you send us an email with it that we can print it out and look at it and use it, or?
That's a really great question. Actually, we're recording this presentation right now, and I will be sending out a link to this recording for everybody who signed up today to be able to access at a later time.
Thank you.
Thank
You're
you.
welcome.
I have a question.
Sure.
I have exercise dystonia where my toes on one foot will curl under after about 10 minutes of doing a brisk walk.
Okay.
And do I need to take more Cinnamon, or what do I need to do to stop that? Because
That's a really good question. And so that problem is not uncommon. So dystonia can happen sometimes if your medicine is wearing off. And so sometimes if your medicine is wearing off with exercise, we'll recommend, hey, take an extra half tablet of like Cinemet or something before you exercise. And again, talk to your doctor who knows about this, but that can, if that helps, then you know, okay, it's a wearing off phenomenon. Sometimes patients will do all kinds of things. They'll say, I tried taking more, I tried taking less, and the dystonia is just, it doesn't matter, it's with that task, okay? And if that's the case, sometimes we'll actually do Botox injections for toe curling dystonia to help kind of relieve that symptom. Did that answer your question?
Yes, that was helpful.
There's also a, some of my patients will use toe separators and that you can get, and they actually are like so there's like rings around your toes, and then it has like a flat thing on the bottom. And don't get the hard ones because they make hard plastic ones. They have like silicone ones that can actually help keep your toes out so they're not curling, and you can wear it inside a shoe. So if you look on like Amazon for like toe separators, that may be helpful for you if that's something, if it's only brief and it happens with exercise and you just want to try some other kind of like an equipment related thing, that's something you could try and see.
I find that if I walk on my tippy toes for about 50 to 100 feet, then all of a sudden the cramping will stop and then I'm able to finish my 2-mile walk.
Oh, I like that. I like that trick. Maybe I'll tell other people to start walking on their tiptoes if that happens.
What about dry mouth? Other than drinking a lot, maybe taking mints or lozenges, anything else?
No, that's a really good question too. There are not, there's no medication for dry mouth, and it can be so frustrating in Parkinson's because like I said, while drooling can be a problem, patients with Parkinson's produce less saliva actually. So the best thing, like you said, is drinking plenty of water. Some people will use biotin, that you can get over the counter. I would say it's hit or miss. Some people feel like it helps. Some people don't, say it doesn't really do anything for them. And then also, again, like chewing gum or like sucking on a lozenge, because that's going to stimulate saliva production. That can help with dry mouth. But unfortunately, there's no pills for dry mouth. And also looking at your medicine list, because you can, some medicines will dry up saliva more than others. Not necessarily related to Parkinson's, but other medications can cause dry mouth. So that's something, if it's a major problem, then having your doctor look through your med list to see if anything may be a culprit there can be helpful.
I have a question during exercise. I have one arm, my left arm is much weaker than the right arm. And I don't know if I'm overdoing it or what's happening, but it feels like electrical shocks. It feels like nerve pain. So I don't know if I'm pushing it and should rest or if I should work through that pain.
I would talk to your doctor about it because it may be a totally unrelated symptom to your Parkinson's. So maybe you have, and it depends on where it's tingling. You may have like a pinched nerve that gets irritated, or you may have a peripheral nerve like a ulnar neuropathy or a carpal tunnel, which is both treated differently than Parkinson's. So I would ask them before just pushing on through,
Ask the primary care doctor.
Yeah. Or even, you can, your, neurologist or whatnot can be helpful because getting a description of, well, where's the numbness? Where's the tingling? Where's the pain?
I see.
What position is it in can help them figure out what's happening and what other diagnostic tests need to be done. So sometimes we recommend EMGs, which are or nerve conduction studies to see, is there a nerve pinch there, and go from there.
Thank you.
You're welcome.
I have a question on 2 medications regarding whether they would lower your blood pressure. Trospium chloride, and tamsulosin. They're two urinary medications.
Yeah, so medicines for urinary issues can lower the blood pressure sometimes. So if that's an issue, I always say talk to whoever prescribes those medicines and see. Unfortunately for the bladder, there's not a lot of medicines So you're kind of limited, right? And so it's kind of balancing these two things regarding the blood pressure and then controlling your urinary symptoms. But sometimes, yes, blood pressure, those bladder medicines can lower blood pressure.
Okay, I asked that because it seems like we're having issues with low blood pressure, and it seems like that particular issue kind of started around a change in urinary medication. So I just wondered if that did do that.
Yeah, no, so it's definitely something to talk to the whoever is prescribing those medicines about, if you've noticed a correlation between when you started those and those symptoms happening.
Okay, thank you.
You're welcome.
I have a question
Sure.
on medication. I recently was prescribed some Lyrica for neuropathy in my feet.
Yep.
And it helped my feet, but I got so lightheaded and dizzy, and
yeah,
it seemed like it got worse when I took the Lyrica, so I've stopped, but I miss it because my feet are burning.
Yeah.
So is that a likely thing that happened from the Lyrica?
So yeah, so Lyrica doesn't necessarily lower your blood pressure, but just like that class of medicine, so Lyrica, gabapentin, in some patients, they can feel a little more dizzy on it or lightheaded. So you may want to talk to whoever prescribed it and let them know. They may try a lower dose or give you some recommendations for how to use it, so that maybe that isn't so much of a side effect. And sometimes those medicines, those side effects get better with time. So like if you initially noticed it and only after 1 or 2 days, you may just need to wait a little bit longer, like try it up for a little bit longer, and those side effects may go away. But I would talk to your doctor.
It got worse over time as I took it, so I quit.
Gotcha.
Okay. Thank you.
You're welcome.
Okay, it's a little bit past noon, and our program was aimed to wrap up around noon. We don't have any questions in the chat, but does anyone else have any additional questions before we wrap up here today? Okay, so I have, I'm going to share my screen real quick. If you guys have any need of financial assistance or prescription discounts, we have this little sheet that Dr. Jacob and Cher Wortley have provided us. I will be emailing this out with the link to our next PD-EDU that is in June. It's making the home accessible, and as well as the recording of this presentation today. So please take a look at your email later next week for that information. Dr. Jacob, we just want to take a moment to thank you for presenting today. This was a wonderful presentation, and I believe I can speak on behalf of everybody that we learned a lot. And thank you so much for taking time on this beautiful Saturday to be with us.
No problem. And I cannot take credit for the handout. That was Becca.
Oh, Becca. Thank you, Becca.
Yeah. So that is credit to her, because
Thank you, Becca.
Thank you, Becca.
Awesome. Well, my apologies on that, but thank you for giving credit where credit is due. I guess since no one else has any questions, feel free to stay on this chat if you guys want to, talk to Dr. Jacob a little bit more, but feel free to head on out. I think our program is over. So
we have a copy of the handout also
of the presentation itself, the one that Dr. Jacob presented.
So we don't have to sit through a whole hour to read one page.
Dr. Jacob, would people be able to get access to your PowerPoint? I'm not sure if that is possible or not.
Sure, I can. Do you want me to send it to you, or I don't know?
Yes, you can send it to me and I will send it out in the follow-up email if you're comfortable with that.
Yeah, that is totally fine with me.
Thank you for sharing. It was very informative.
No problem.
Thank you, Mo. That was a great question. Yes, I will add that presentation to the email. Any other questions before we all skedaddle today?
Nope.
No. Well, thank you guys for joining us today on this beautiful Saturday. We'll see you guys at June's PD-EDU.